It is another tremendous honor to be able to introduce today's policy plenary talk. As we've been planning this conference, you know, we get abstracts in and we get the reviews come in, and then we meet in October to look at the conference and to look at what's come in. And it was so exciting to see a symposium session come in on the new Surgeon General's report on smoking cessation. If you can put my slides up. So we thought that this was of tremendous importance and interest to the membership and decided to elevate this to be a policy plenary for this year's meeting. And we're so honored to have the Surgeon General here to introduce the report and to talk about the important findings. Dr. Jerome Adams is the 20th Surgeon General of the United States. His mission as the nation's doctor is to advance the health of the American people, and his motto is better health through better partnerships. Hello.
Hello. We're going to do the...
So as the Surgeon General, Dr. Adams holds the rank of Vice Admiral in the U.S. Public Health Service Commission Corps. In this capacity, he oversees the operations of approximately 6,500 uniformed health officers who serve in nearly 800 locations around the world, promoting, practicing, and advancing the health and safety of our nation. He's a doctor. He's a public health professional. We are so honored to have him here today. We have a few other speakers as well who will be joining via WebEx, who are senior editors on the report. And I just have to say, going to your website, I know you have a lot on your plate right now.
Just a little bit, just a little bit.
But we see your commitment to tobacco control on this page. There's who is the Surgeon General? The next topic is e-cigarette prevention. The third is tobacco reports and publications. Your dedication to the field and to this work is so important and really evidenced by you being here today. Thank you so much for joining us, and I turn it over to you.
Thank you. Oh my gosh, glad to be here. Well, good afternoon, everyone. Oh my gosh, everyone stand up for a second. Stand up, shake it out a little bit. Roll your heads around. And the other way. All right, deep breath in, and out. And in, and out. All right, now we're ready. Okay, grab a seat. Good afternoon, everyone. Much better, much better. Thank you so much for that very kind introduction. And because it's the elephant in the room, we're going to start off talking about COVID. And I want to, first of all, say to each and every one of you that I really encourage you throughout the rest of this meeting and throughout the next several weeks to really try to be safe. Try to be safe. Try to think about those basic public health practices that we know will help keep us safe. And I want to applaud SRNT and the staff of SRNT and the Hilton for taking measures to keep you all safe. And we actually had a meeting yesterday before I came here, and I said, I want to know what you all are doing to help keep the people who are the SRNT participants safe. And I got to tell you, they had a plan that was more than 10 points for all the things that they were doing to make sure you had hand sanitizer available, to make sure you all were able to practice social distancing, to make sure you understood all the different things that you could do and that they were doing, including we talked about keeping the doors open so you wouldn't have to pull back and forth on door handles and touch door handles. But again, really want you all to be safe. I want to give you some COVID-19 context because there are a lot of people who are probably surprised that I'm here right now. Well, it's important for us to understand that more people are going to die in the next hour from smoking-related illnesses than have died in the United States from COVID-19 so far. And one of the challenges of being Surgeon General is everyone wants me to lift up their issue. And it's important for me to help America keep things in perspective, but also important for all of you to help people understand that we can't forget about one problem our society has when we're focusing on another problem, because we may end up net losing overall. And so important that we continue to lift up the impact that tobacco has on our country. And it's also important to know that the people who are most at risk for COVID-19 are those with chronic diseases. Diseases like heart disease and lung disease. Diseases that are disproportionately caused by and exacerbated by smoking. So one of the things we can do to help keep our country safe from COVID-19 is to help keep people from starting smoking and help people stop smoking. Amen. All right, I got one out there. I have a three-part prescription for America to help them stay safe from COVID-19 that I want to go over really quickly. Number one is know your risk. And we've learned a lot about this disease. Interestingly enough, 80% of people who have been diagnosed with COVID-19 actually have a mild disease or no symptoms. Important for people to understand, there will be more cases. Most people are going to be fine. Most people are going to be just fine. Of that 20% who go on to need medical attention, there is a smaller subset that will have severe disease and die. And we know a lot about that group now, too. We know that it's mainly 80-year-olds, 80-plus-year-olds who have chronic medical conditions. So a lot of our focus now is really on making sure we're protecting the most vulnerable, while helping everyone else understand that, yes, by the time all this is said and done, many of you all in this room, if not all of you, will know someone who has been diagnosed with COVID, and many of you, and hopefully all of you, will be able to say they got through it just fine. They got through it just fine. So know your risk, number one, because when you know your risk, then you can make appropriate decisions. If you are a 60-plus-year-old with chronic medical conditions, you should not be here right now. You should not be in large public gatherings because you are at higher risk, which leads to number two, understand your circumstances and environment. Once you know your risk, then you've got to say, okay, because we've all got to keep living our lives. Then you've got to say, okay, am I planning on going to the movies? Well, I'm at higher risk. Maybe I shouldn't do that. Am I planning on going? Someone asked me earlier about whether or not they should go to a wedding next weekend in Georgia. Well, I said, again, if you are at high risk or you're coming back home to someone who is at high risk, then maybe you shouldn't get on a train and go several states away to go to a wedding. Understand your work environment. Is telework an option? Are you planning on going to church this Sunday? Making sure, again, you know your risk and then you understand your environment and circumstances. And then the third point of my prescription is know how to protect yourselves and your community. And I would encourage you to go to coronavirus.gov for updates. And we update that website daily with information on coronavirus. I've done a lot of interviews over the last 2 weeks. There is not a question I've been asked by an interviewer that isn't addressed on coronavirus.gov. And your state departments of health all have great information tailored to your state so that you can understand, do I live in a hot spot? Because again, that's part of knowing your environment and your circumstances. You're going to behave differently in Seattle right now or in New York right now than what you're going to behave in Louisiana. But you can find out that information by going to your State Department of Health website. Coronavirus.gov has information out there about how you can stay safe, tailored to specific audiences, individuals, families, workplaces, schools, places of worship. Now is the time for us to prepare, and I don't want to downplay the seriousness of this any more than I downplay the seriousness of 20,000 people dying from the flu in this country so far this year. It is not what we're trying to do in terms of downplaying the seriousness, but we want to prepare and not panic. It is my belief as Surgeon General that more people will die from misinformation, from panic, from stigma and discrimination as a result of COVID-19 than are going to die from the actual virus. And so we need all of you to help spread the facts and not fear, and to, again, help people understand this is going to be a rough ride for the next couple of weeks. But if we come together and do the things that we know are effective in preventing the spread of infectious diseases, we'll be safer from COVID. We'll actually have less flu deaths. The silver lining here is that we're in the midst of a terribly bad flu season, and I would be telling all of you anyway to use hand sanitizer and to practice social distancing from people who are sick, and maybe we'll save a few lives from the flu, and we will get through this. Now, let me get back to why I'm here. I want to say thank you to all of you, because it's because of you that we were able to release Smoking Cessation, a report of the Surgeon General. I'm going to go over some highlights from that report. Despite substantial progress in the areas of smoking cessation, and important to understand, we are at historically low levels of smoking in this country thanks to the people in this room. But 34 million Americans still smoke. The good news is that 70% of U.S. adults who currently smoke cigarettes say they want to quit. Not enough people know that. It's important for you all to be tweeting out through your social media channels, helping other people understand, because there's this misconception out there that people are smoking because they want to smoke and they don't want to quit, and by golly, they're a lost cause. And far too many people think that, but 70% of smokers want to quit. It's very personal to me, as I lost both of my grandfathers to smoking-related illnesses. I grew up with asthma, watching both of my grandfathers smoke, riding in the car with them, having my asthma exacerbated, watching one die of a stroke and the other die of lung cancer. And I often wonder if one or both of them would have lived to see my children, their great-grandchildren, if they'd had more help quitting. Tobacco dependence is a chronic and often relapsing condition that is driven by an addiction to nicotine. As a result, quitting smoking is often one of the hardest things a person can do in their life. And I don't want to jump around on too many tangents here, but my brother is actually in a rehab facility right now for his heroin addiction. And many of you have heard me talk about that. I've heard him and other people say that quitting cigarettes was harder than quitting heroin. It is one of the most addictive substances known to man. And before people lose their minds, I am not comparing one to the other. I am telling you that for some people out there, quitting cigarettes is as hard or harder than quitting opioids. But while quitting is hard, we know it is possible. In this report that I hope you all have looked at, the executive summary, it's on my website, includes the latest science on interventions that have been proven to help people quit smoking. We know a lot about the benefits of keeping people from starting smoking, but this report highlights that quitting smoking is one of the most important actions a person can take to improve their health. And I know you all get this, but important for people to understand, because people will say, well, the Surgeon General's been talking about smoking for years. 34 different reports. What's new about this? Well, what's new is that 32 of the other reports all essentially said starting smoking is bad for your health. This is just the second one ever, and the first one was 34 years ago, that actually says that quitting smoking is effective in terms of promoting your health. So if you or a loved one or a smoker who has tried to quit or wants to quit, the fact is there's literally never been a better time to make a quit attempt. We know more than we ever have about the science of quitting. In the 3 decades since the first Surgeon General's report came out on smoking, the world has changed dramatically. We didn't have our smartphones back then. We didn't have social media. We didn't have FDA-approved smoking cessation medications. And with research, medical advances, and years of documented experience in tobacco control, again, we know more than ever about the science of quitting. My report highlights the broader systems of support and policy interventions that encourage, accelerate, and sustain quitting success. And it further addresses the health benefits derived from quitting smoking by subcategories and the unique populations who disproportionately face the burdens of tobacco use. Cigarette smoking has declined considerably from nearly 43% when the 1964 Surgeon General's report was published. Back then, almost half our country was smoking. We are now at a historic low of 14%, and it represents one of the greatest public health achievements of the past century, and for that, you should give yourselves a round of applause. But again, 34 million US adults still smoke. Smoking remains the largest preventable cause of disease, death, and disability in our country. It harms nearly every organ of the body. Nearly 500,000 Americans die from smoking each and every year. And cigarettes are, to the best of my knowledge, the only legally sold product that, when directed, kills half the people who use them. In addition to the human toll, there's a fiscal cost to our country, $300 billion with a B dollars each and every year. So helping more people quit with the tools in this report isn't just the fastest approach to improving our nation's physical health, it's also the fastest approach to improving our fiscal health. And a whole lot of people are worried about the stock market out there right now. They're worried about our businesses. Number 2 cost for most companies is healthcare expenses. Number 1 driver of healthcare costs are the people who are still smoking and aren't being given the tools and the opportunity and the advice to help them quit. The report, and again, this is an executive summary, contains 700 pages of the latest science around smoking cessation, was the result of an enormous undertaking by many contributors, many of whom are in the audience. Do we have any contributors here? If you're here and you contributed to my report, can you stand up? Nobody in the audience who contributed? Well, the authors aren't here, but you all contributed to this report. You all helped with the studies, with the science, with the enthusiasm that allowed us to write this report. Been developed over 3 years by a senior scientific editorial team through coordination with the CDC, using the same scientifically rigorous peer-reviewed standard that has been the hallmark of U.S. Surgeon General's reports on tobacco since their inception. And this is important too, because people are attacking institutions of government now for a variety of reasons. People are questioning whether or not you can trust the science anymore. It is important to understand, Surgeon General's reports are the gold standard on which everything else out there is based in terms of how you conduct a review of the data. More than 200 individuals worked to compile this review. And Dr. Jillian Schauer, is she going to be still sharing the stage virtually with us afterwards? All right, wonderful, and I'm glad you're going to get to ask her some questions. Although they couldn't be here today, I'd also like to personally thank my colleagues at the CDC, and especially the Office on Smoking and Health, with a special shout out to Brian King, Leslie Norman, and Corinne Graffunder, the director of the Office of Smoking and Health. And finally, a sincere thanks to our state, local, and national partners, again, many of whom are in the room today. Without you all, this report wouldn't have been possible. Now, to turn to the report itself, it is comprised of over 101 chapter conclusions and 10 major conclusions overall. Again, please go to surgeongeneral.gov, take a look at them. The report, it documents an array of effective clinical and health systems interventions for treating tobacco use and dependence. And it further reviews the evidence on the effects of population-based policies. So we've got many tiers at which we can lean into smoking cessation and interventions on smoking. To provide context for the report itself, I want to quickly walk through what we know from the major conclusions of the report. We know that quitting smoking can add years. Did I hit a button? Or they just didn't want to see me anymore? Well, quitting smoking, thank you, that was wonderful. You can leave those up there. It's beneficial at any age, and this is true whether you are 27 or 72. It is never too early or too late to quit. That one's important to me because you've got a lot of folks out there who say, I've been smoking for 30 years, 40 years. What's the point of quitting right now? The damage is already done. This report shows that at any age, you can get a better quality of life and live longer if you quit smoking. Quitting smoking can lower a person's risk of early death and add as much as a decade to their life expectancy. Let the significance of that sink in. Quitting smoking can add 10 years to a person's life. That can be the difference between seeing your son or your niece graduate from high school. That can be the difference between watching your daughter get married and dancing with her at her wedding. 10 years. That can be the difference between whether or not you see your kids or your grandkids or your great-grandkids play their first baseball game or have their first soccer game. Again, smoking is costly. Findings included in the report highlight that quitting smoking can reduce financial burden on individual smokers themselves. And I love this. Talking to a guy who we added up the individual cost of smoking, and he goes, well, heck, with that much money, I could buy a new truck. Well, yes, you could. And we need to do a better job of helping people understand how much that pack of cigarettes a day or every couple of days actually adds up to if we can help them quit smoking. Because in many cases, that may be the motivation they need to start on their pathway to being nicotine-free. It also talks about private and public healthcare systems' financial burdens and society's financial burden from smoking. And quitting smoking reduces the risk for serious health conditions, including 12 different types of cancer, all laid out in the report, heart disease, lung disease, and reproductive health systems. It's interesting, and they don't like when I say this, but I think we should be telling more people this. Your love life will improve if you quit smoking. And the Surgeon General and the report that we have out there now says that. So every time you see that commercial about that little blue pill, think about the fact that we should have a commercial with a red report saying, we can improve your love life if you quit smoking. So the science is clear about the benefits of quitting smoking from a health and an economic perspective. But again, important to know that half of adults who smoke try to quit in any given year, but face many challenges. And these are laid out in the report. Over 40% of smokers, and this was the most shocking statistic to me as a provider, 40% of smokers who see a health provider each year are not advised by their health providers to quit. They are not. 40% are seeing a health provider, not being told to quit. Why is that? Because I'm a dermatologist and you came to me for your eczema. You didn't come to me to get lectured to about smoking. I'm an OBGYN. You came for your annual pelvic exam. You didn't come to be lectured to me about smoking. Well, as a doctor, we took an oath to heal people. And by golly, yes, I want to take care of your eczema, but your quality of life is going to be improved to a greater extent, and you're going to live longer if we lean into your smoking and take just 30 seconds to ask, advise, and refer you to the quit line, as any other thing that I can lean into. 2/3 of smokers who try to quit don't use FDA-approved medications and counseling, which have been proven to increase the probability of quitting. And I know there's a lot of people out there who, I don't want to say a lot, but there are people out there who knock some of the FDA-approved quit medications. The fact is, there are 7 FDA-approved quit medications. There are different options for different people. And combined with behavioral counseling, they double your chances of quitting. They double it. Another challenge is that disparities in smoking and cessation behaviors persist in our nation. And as a black man who has lost several family members to smoking, I think it's important that we lift that up. The prevalence of cigarette smoking remains highest among persons with a GED, persons with behavioral health and substance use disorders. The report says 40% of the combustible cigarettes in this country are consumed by people with a behavioral health and substance use disorder. 40%. Why? Because we think they have bigger fish to fry. But if you help them quit smoking, you empower them, and you actually improve their behavioral health. Persons who are Medicaid enrollees and the uninsured smoke at higher rates. American Indian and Alaska Natives smoke at higher rates. Members of the LGBTQ community smoke at higher rates and don't quit as often. Persons who live in the Midwestern and southern regions of the United States, and I've seen it just walking on the streets here in Louisiana. Many more people smoking here than in Washington, D.C. We need to make sure we're targeting our interventions to the persons who are most at risk. Persons with a low annual household income, and then disabled persons. So again, 34 million Americans still smoking. The problem is that where I live in Tysons Corner, Virginia, I don't see many of these people on a day-to-day basis. A lot of our country thinks we've got this smoking problem licked. And it's up to you all to make sure we dig in to those communities that are most affected and give them the tools so that they can quit. We learned that cigarette smoking can vary greatly among other subgroups. A smaller percentage of Hispanic and Latino adults overall smoke, but The number of cigarettes smoked per day is highest among Cuban and Mexican smokers than smokers from other Hispanic and Latino groups. Smoking cessation opportunities, including quit attempts, receiving advice to quit from a health professional, and using cessation therapies, also vary greatly across populations. And as an example, African Americans are less successful at quitting than white and Hispanic cigarette smokers. We need to dig deeper into why that is and lean into those communities with culturally and ethnically sensitive interventions. We know these disparities may be affected by variables such as receiving advice to quit from a health professional and being advised to use evidence-based cessation treatment, as well as differences in state and local tobacco control policies, healthcare coverage, and tobacco product marketing. We know the tobacco industry has a long history of marketing to many of these subpopulations that I talked about. So there's still much more work to be done, and this report helps us understand where and how we should be targeting our efforts. While quitting smoking may not be easy, it is possible, especially when people who want to quit, and again, 70% of smokers want to quit, 50% make a quit attempt every year, are connected to proven treatments that are both safe and effective. Behavioral counseling and FDA-approved quit medications are effective, and they are cost-effective, and they increase a person's chance of successfully quitting. We know counseling is now available in a variety of formats, including individual, group, and one-on-one counseling over quit lines. And we know the times are also evolving, so we must evolve when it comes to offering cessation services. The report tells us text messaging services are effective in increasing quit rates, encouraging people, checking in on them, as are web or internet-based interventions. To ensure people who want to quit have meaningful access to counseling and medications, the report tells us that the health systems and payer levels having comprehensive barrier-free insurance coverage for cessation services is important. And I'm excited about this because more people are talking about outcomes-based reimbursement. We need to take advantage of that to help people understand it is a very pound-foolish and penny-foolish decision to not make barrier-free smoking cessation services available to everyone who wants to quit. According to our report, comprehensive coverage and promotion can increase the use of these treatments, leads to higher rates of successful quitting, and is cost-effective. Having highlighted the report's findings about strategies at the individual and systems levels, I want to finish on population-level strategies because, again, there are things we need to do for each and every patient. There are things our health systems need to do, but there are things that our policymakers need to know about and that you all need to lean into. This report details a number of interventions proven to decrease smoking on a population level, including raising the price of cigarettes, adopting smoke-free policies, implementing mass media campaigns, and requiring pictorial health warnings on cigarette packaging. We do these reports so that you all can go to your state legislatures and local chambers of commerce and say, we need to do this in our community because the Surgeon General of the United States says it's a best practice. It's also important to support fully funded, comprehensive statewide tobacco control programs. And while discussing interventions and innovations that can help individuals quit smoking, the question is inevitably raised about the potential role of e-cigarettes. So, I want to address this issue starting with the language of the major conclusion related to e-cigarettes that's included in the report. E-cigarettes, and this is the language I'm reading here verbatim, and I want to remind you again, gold standard, 200 experts from all across the world looked at the data and decided that this was the appropriate language to summarize the most currently available data on e-cigarettes in terms of whether or not they help people quit smoking. E-cigarettes are a continually changing and diverse group of products that are used in a variety of ways. Therefore, it is difficult to make generalizations about their effectiveness for cessation based on studies of a particular e-cigarette. And the 200 people who contributed to this report said, there is presently inadequate evidence to conclude that e-cigarettes in general increase smoking cessation. Now, I've heard powerful accounts from many individuals, and any of you all who follow me online know that there is no shortage of powerful accounts on my social media feed from individuals who have used e-cigarettes to quit smoking. But this report is based on experts reviewing the totality of scientific data about what works on a population level to help people quit. And these experts concluded that more research is needed on whether, how, and which e-cigarettes might be an effective quit aid, and to better understand the health effects of e-cigarettes. And I say that to you all not as an admonition, but as a challenge. We need more research. We need you all to look at which types of e-cigarettes, which dosage, which additives, which combinations, which subpopulations are going to be effective to help people quit, so that we can make a real and genuine recommendation to people that is based on the science. It's also important to note that irrespective of ongoing research related to e-cigarettes as a potential cessation tool for adult smokers, this cannot, it must not, it will not come at the expense of escalating rates of use of these products. So I want to be clear. E-cigarettes are not safe for youth, for young adults, for pregnant women, and for adults who currently do not use tobacco products. And we have to continue to message that while we're doing the research to figure out when, where, how, if e-cigarettes are on a population level an effective cessation aid for adults who smoke. I know this was a lot of information. Hopefully it provides a snapshot of the richness of scientific data and findings included in the 700 pages of this overall report. I would have brought the other one, but it was too big to fit in my suitcase. But findings like those contained in the report are crucial to inform ongoing efforts around smoking cessation. And we know that the science will continue to evolve and help to improve our understanding of what works to help people quit. I want America to know that smoking cessation, a report of the Surgeon General, is a blueprint for continued, coordinated, and collective action amongst each of us as stakeholders. The intent behind the development and release of Surgeon General's reports is not only to report on the science, but to encourage application of the science to improve the health of our nation. Otherwise, those 700 pages are just a doorstop sitting in my office. Most of the 34 million American adults in America who smoke cigarettes want to quit. It is incumbent upon all of us to connect them with the effective treatments and the motivation to help them do so. We need to really lean into the barriers that are preventing them from doing what they already want to do, but are finding it difficult to do. We know coordinated efforts providing treatment and support across multiple sectors can help people quit smoking for good. Equipped with both the science and the resolve, we have the ability to end the tobacco epidemic in America. Working together, we can take the completely preventable tragedy of tobacco-related disease, disability, and death, and make it a thing of the past, so that no other Surgeon General has to stand before you and tell you that he lost both of his grandfathers due to smoking-related illness. In closing, I want to thank SRNT for inviting me to speak today, for making accommodations to keep all of you and to keep me safe. And I want to encourage you to keep doing what you're doing to help make America healthier and to help make America tobacco-free. Thank you.
Rachel, this is Jillian. I can hear you. I'm not sure they've looped us into the stage yet.
We can hear you now. So we're going to move on to presentations from senior scientific editors on the report.
Thank you so much, Dr. Adams, for your leadership on this important public health issue. I am Dr. Rachel Grana from the National Cancer Institute's Tobacco Control Research Branch. And it is my true honor to be here, even if virtually, with Dr. Schauer to represent the senior scientific editorial team and share the important findings of this 2020 SGR on smoking cessation. This report, as Dr. Adams highlighted, was prepared by the U.S. Department of Health and Human Services and was coordinated by the Centers for Disease Control and Prevention with the Office of Smoking and Health and the HHS and the Office of the Surgeon General. And these are the scientific editors as well as the managing editorial team. And it really is an honor to have shared this process with them. All of the funding to develop the report was provided by the U.S. government, and therefore there's no industry funding, and we will not discuss any off-label medication uses today. So as Dr. Adams reviewed, this is a very carefully constructed and standardized process to develop a Surgeon General's report and takes time to execute. The report was compiled using a peer-reviewed, balanced, comprehensive process, which is really designed to maximize scientific rigor and partiality. And under the leadership of the team of senior scientific editors, the report chapters were written on the topics that people are experts on. The content of the report was peer-reviewed by additional experts. Following that peer review, even more senior scientists and other experts examined the scientific integrity of the entire report. And after that process, the whole report goes to agency clearance. And now we are at the gratifying stage where we get to share it with an important audience like all of you here today. I also want to highlight the many companion materials that were expertly prepared that are both in print and online and carefully created to reach the public and our intended audiences, of course, for use in our communities and clinics to ensure we can put these findings into action and help people who smoke and use tobacco. And as these numbers show and were highlighted earlier, the development of this Surgeon General's report is an incredible effort by hundreds of people, including 32 chapter authors, 46 peer reviewers, 20 senior scientists, that has now culminated in 8 very comprehensive chapters on this topic, 10 major conclusions, which were so expertly highlighted by Dr. Adams, and 101 chapter conclusions. So really a quite monumental achievement. And as has been the standard for Surgeon General's reports for many years, this report utilizes a 4-level hierarchy of categorization for interpreting the evidence. So I wanted to make sure that we all understood what those are today. So the 4 categories are that the evidence is sufficient to infer a causal relationship, the evidence is suggestive but not sufficient to infer a causal relationship, the evidence is inadequate to infer the presence or absence of a causal relationship, or the evidence is suggestive of no causal relationship. And consistent with past SGRs on tobacco, there are frequently offered recommendations for research, policies, or actions that are not just limited to those causal categories made in the report. As you heard from Dr. Adams, this is the first Surgeon General's report since 1990 to focus solely on quitting smoking and highlights what we've really learned about smoking cessation over the past 30 years. The report was organized into these 8 chapters covering patterns of use, new biological insights into cessation, health benefits of cessation, benefits on morbidity, mortality, and the economic costs, smoking cessation interventions, and the population strategies that promote and support cessation, as well as a vision for the future steps to maximize the benefits of smoking cessation for all. It also touches on areas with implications for smoking cessation, like e-cigarettes, and the regulatory approaches like reducing nicotine content in cigarettes. So Chapter 1 mainly focuses on providing an overview of the report and the current landscape of smoking cessation since the 1990 report, and contains the 10 major conclusions, which Dr. Adams already presented today. So Dr. Schauer and I are really going to focus on drilling down just a bit further to some of the major findings from each of the remaining 7 chapters. I'm going to focus on chapters 2 to 4, and then Dr. Schauer will focus on chapters 5 to 8 and wrap up our remarks today. Let's begin with Chapter 2. Chapter 2 documents the key patterns and trends in cigarette smoking cessation in the United States. It primarily focused on adult data, but there are data and conclusions about cessation among youth and young adults as well that I'm not going to have time to go into today, but I think are very important to highlight and that you all know that that is there. So some of the major, the evidence review really illustrated that in the US, we've had a lot of progress in the past 30 years. More than 3 out of every 5 adults who were ever cigarette smokers have quit smoking. And by measures of smoking cessation behavior, past year quit attempts and recent and longer term cessation have also increased in the past 2 decades among adult cigarette smokers. But as Dr. Adams really emphasized and drove home nicely for everybody, we have a lot of progress to make. Despite these encouraging indicators, 34 million Americans still smoke, and cigarette smoking remains the highest among certain subpopulations, such as people with mental health conditions and substance use disorders, low FCS status, Medicaid enrollees, lesbian, gay, bisexual, transgender adults, and American Indians and Alaska Natives. In addition, there are marked disparities in the cessation behaviors as well by population subgroup. There are very important disparities like making a past year quit attempt and achieving recent successful cessation across population subgroups defined by educational attainment, poverty status, age, health insurance status, and other indicators. And these disparities may be affected by systemic variables like lower levels of receiving advice from a health professional to quit and less use of evidence-based treatments. However, since 2000, we have seen an increase in smokers receiving advice from health professionals to quit, which is laudable, but we do have a disparity here still. 43% of adult cigarette smokers who saw a health professional during the past year still did not receive that advice to quit. And more adult cigarette smokers are using evidence-based cessation counseling or medication in their quit attempts, yet 2/3 of cigarette smokers who tried to quit in the past year did not use the evidence-based treatment. And there are disparities in receiving advice to quit and use of evidence-based treatment by age. Where younger smokers are more likely to be lighter smokers and non-daily, they're often not identified by a healthcare professional systematically or offered the advice to quit. And a large proportion of adult smokers report using non-evidence-based approaches when trying to quit smoking, such as switching to other tobacco products. So, which also highlights the need to really reach people with these evidence-based treatments. And you'll hear more about interventions to support this in chapters that Dr. Schauer will review. This graph shows the quit ratio over time since about the first SGR, 1965 to 2017. This metric represents the percentage of adult ever smokers who have quit smoking and is defined as the number of former smokers divided by the number of ever smokers. So this is a trend over time, demonstrating that there's an increasing trend in the population-based quit ratio since 1965. For example, you can turn your attention to some recent years from 2012 to 2017, where you can see a 6 percentage point increase in the quit ratio. And the quit ratio has been consistently higher among older adults versus younger adults. So taken together, the findings of this chapter really highlight that while we've made significant progress, there's still more work to do to address these disparities, in particular, increase our reach and utilization of evidence-based treatment. Chapter 3 focuses on how biology can influence smoking cessation. This is a pretty dense chapter for many of us, including us behavioral scientists. And I think that what I really want to emphasize here, I will review these major findings, but I do want to emphasize the new biological insights. And thus, by nature, this chapter is a little more explorative and covers some novel topics. And as such, not surprisingly, the conclusions in this chapter met the suggestive but not sufficient threshold. This type of work is really important to inform our ongoing dialogue about cessation, but these are very much emerging topics that warrant more nuanced research before stronger recommendations can be made. So this chapter, let me tell you a bit about how this chapter is organized and what it accomplished. It really focused on 4 areas of intensive research domains that progress was made since the publication of the 2010 Surgeon General's report. The first domain is in the cellular and molecular biology of nicotine addiction. And this section describes the preclinical basis for understanding nicotine addiction and the ways that this knowledge can be used to enhance cessation. The second domain is vaccine and other immunotherapy. And this focuses on presenting the conceptual basis of vaccine treatment design, progress that has been made, barriers that were encountered, as well as approaches to the next generation of research in this area. The third domain was evidence to reveal insights into smoking cessation from the field of neurobiology, focusing on our advances in understanding the brain circuitry involved in nicotine dependence, primarily through advances in brain imaging techniques, the roles of stress, craving, reward, and changes in cognitive control on addiction, and they provide further insight into the effects of smoking on the brain to identify new targets for cessation. The fourth intensive research domain was on genetic studies of smoking phenotypes. This evidence review focused on our mechanistic understandings gained in recent years, as well from the genetic literature, as well as advances in methodological approaches that can be employed to understand this. So rather than read all of the conclusions on this slide, which would take a bit more time than we have today, I'm going to just summarize some of the major takeaways from this chapter. First, we have a lot of substantial research in the cellular and molecular mechanisms of nicotine addiction, including the rewarding properties of nicotine, withdrawal symptoms, and relapse. That is more well known. We have good animal models and a wide array of medications that target these various neurotransmitter systems, and new ones are in development. With regard to the vaccine research, in summary, the nicotine vaccines are possible in the future. Based on research, they will be stimulating the immune system to produce antibodies that reduce or slow the delivery of nicotine to the brain. That's the approach that seems to be taken. And animal studies have shown promising results, but more research is still really needed in humans, especially to reduce intolerable side effects. With respect to the brain imaging research, brain imaging technologies such as MRI and fMRI have really been useful in helping us understand how the brain changes during nicotine addiction and how smoking cues and anti-smoking messages affect brain function. And the evidence from the genetic research reviewed in this chapter suggests that someday we may be able to tailor cessation treatments to genotypes. However, this chapter really underscores that more research is needed regarding nicotine dependence and the role genes play in smoking, nicotine addiction, and cessation. Turning now to chapter 4. Chapter 4 was a very extensive chapter. It reviewed our knowledge of disease risks from smoking, and really what is added in this report is how those disease risks are changed by and impacted by smoking cessation. It's organized into these effects by major type of chronic diseases like cancer, cardiovascular impacts, respiratory impacts, and a wide array of reproductive outcomes. So overall, the evidence reviewed in this chapter shows that there are in several areas of disease risk, smoking cessation reduces risk. With respect to cancer, the evidence is sufficient to infer that smoking cessation reduces the risk of 12 cancers. They are all listed on the slide. I won't read them for you today. And the evidence is sufficient to infer that the relative risk of lung cancer decreases steadily after smoking cessation compared with the risk for persons continuing to smoke. With regard to cardiovascular disease, there are 15 chapter conclusions about the impact of smoking cessation on cardiovascular disease. But in summary, quitting smoking reduces the risk of morbidity and mortality and the burden of disease from cardiovascular disease and stroke. The risk of developing coronary heart disease drops rapidly after quitting and then declines more slowly over time. And there are many more substantial and conclusions where the evidence is sufficient that you can see more in the report. For smokers already diagnosed with coronary heart disease, there were major conclusions of benefit. The evidence is sufficient to infer that quitting smoking can also improve outcomes for adults who have already been diagnosed with coronary heart disease. In patients who are current smokers when diagnosed, the evidence is sufficient to infer a causal relationship between smoking cessation and reduction in all-cause mortality. It's sufficient to infer a causal relationship between smoking cessation and reduction in deaths due to cardiac causes and sudden death. it's sufficient to infer that a causal relationship between smoking cessation and reduced risk of new and recurrent cardiac events. With regard to chronic obstructive pulmonary disease, previous Surgeon General's report have really elucidated the many ways that tobacco smoke injures the lungs and causes respiratory injury and contributes to chronic respiratory disease and health benefits from smoking cessation for COPD. The present evidence reviews serve to reinforce that quitting smoking remains the only known way for persons with chronic obstructive pulmonary disease to reduce their loss of lung function over time, and for adults who currently smoke to reduce the risk of developing COPD. And the last subsection of Chapter 4 under the health benefits covered the impact of cessation on several different aspects of reproductive health, as evidenced by the 21 chapter conclusions. To summarize many of the main findings, though, here in brief, the evidence is sufficient to infer that smoking cessation by pregnant women benefits the health of for themselves and that of their fetuses and newborns. The evidence is sufficient to infer that women who quit before or early in pregnancy gain more weight during gestation than those who continue to smoke. And the evidence is sufficient to infer that smoking cessation during pregnancy reduces the effects of smoking on fetal growth, such that quitting smoking early in pregnancy even eliminates the adverse effects of smoking on fetal growth. So what that means is that smoking cessation before or in early pregnancy reduces the risk of delivering a low birth weight baby. So as you can see, there are many very well-documented health benefits for smoking cessation. And now I'm going to hand things off to Dr. Jillian Schauer to provide an overview of the remaining chapters and a good wrap-up of our presentation today. Thanks so much.
Thanks, Dr. Grana. Do you want me to do the slides, or are you going to do that?
No, that's okay. Now I'm going to stop sharing and you can share.
Okay, gotcha. Hello, everybody. This is Jillian Schauer. Hello from Seattle. And my apologies that I can't be with you in person. I'm a senior consultant for the Centers for Disease Control and Prevention, as well as a co-director of the Tobacco Studies program at the University of Washington. Let me just share my screen and I'll pick up where Dr. Grana left off at Chapter 5. So Chapter 5 considers broad indicators of the burden in relation to smoking cessation. Hopefully it's launching for you. There you go. And it includes morbidity and mortality, economic costs, and this type of information, I think the senior editors of the report felt was vital to include in this report because it can inform smokers about the potential benefits of quitting, and it can really serve as a strong rationale to provide interventions to help increase cessation. So again, very briefly, we're just giving you highlights. The sufficient level conclusions from this chapter span from the individual level to the system to society. There was sufficient evidence to conclude that smoking cessation improves well-being, quality of life, overall health status. There is also sufficient evidence that smoking cessation reduces mortality and increases the lifespan. And there was sufficient evidence that smoking has a high cost to smokers, health systems, and society. There was also sufficient evidence that smoking cessation interventions are cost-effective. Moving to Chapter 6. Chapter 6 and Chapter 7 are very meaty, robust chapters. Chapter 6 focused on interventions and treatments for nicotine dependence. It builds on research that was conducted since the 2008 U.S. Preventive Services Task Force Clinical Practice Guideline that I know all of us are familiar with. This chapter covers behavioral treatments, modes of delivering those behavioral treatments, pharmacological treatments, combinations of behavioral and pharmacological treatment, modified and alternative tobacco products, including, as Dr. Adams mentioned, very low nicotine content cigarettes and e-cigarettes. It also covers teachable moments in which cessation treatments might have particular or increased effects, and subpopulations like pregnant women, adolescents, dual tobacco product users, and light and non-daily smokers for whom there might be some unique considerations when we think about cessation. So similar to the 2008 Preventive Service Task Force Guidelines, Clinical Practice Guidelines, this report found sufficient evidence that behavioral counseling and cessation medications are effective alone in increasing smoking cessation and that they're more effective when used together. The report also found sufficient evidence to suggest that combining behavioral counseling and medication increases smoking cessation compared to self-help materials or to no treatment. So again, those are very similar conclusions to what we have from the 2008 clinical practice guidelines. In terms of behavioral interventions, the report found sufficient evidence that proactive quitline interventions alone or in combination with medication can increase cessation. And proactive means that the quitline reaches out to the person as opposed to just relying on the person to be the one calling into the quitline. The intervention is not, wholly dependent on the person. So I think that's a very important caveat. In terms of how we deliver these behavioral interventions, the evidence was sufficient to infer that short text messages about quitting independently can increase smoking cessation, and that those text messages are most effective when they are interactive or tailored to the individual responses. So this is a conclusion that really takes into account science that's happened since 2008, since that clinical practice guideline came out. We also found sufficient evidence that web or internet-based interventions increase smoking cessation, especially when they're delivered using proven behavioral change techniques. So for example, if they're delivered using techniques based on motivational interviewing or cognitive behavioral therapy, that would make those web-based interventions more effective. The evidence was inadequate for smartphone applications at this time. In terms of medication treatments, the evidence is sufficient to infer that combining short and long-acting forms of nicotine replacement therapy can increase smoking cessation compared to using just one form of NRT. Again, this is an advance based on the science since 2008, and something that I think the senior editors as well as the Centers for Disease Control feel is important that we work to put more into practice. So combining medication has value. The evidence was suggestive but not sufficient that preloading, which means you're starting a medicine in advance of a quit attempt, especially with the patch, can increase cessation. In terms of modified and alternative tobacco products, the evidence was suggestive but not sufficient that very low nicotine content cigarettes can reduce smoking and nicotine dependence and can increase cessation. Some of the challenge in the body of work that exists, and for those of you who were in the room for the speaker before us, I think she really highlighted the spectrum of work in an excellent way. These studies have been conducted in a context in which full nicotine cigarettes are available. And so the effects might be greater in an environment in which conventional cigarettes and other combustible tobacco products are not readily available. And there have been challenges, as was alluded to in the earlier presentation, in being able to figure out how to study that. With regard to e-cigarettes, I think the report clearly acknowledges that this is a heterogeneous class of products and includes a variety of products. You can see from the picture, first generation, second generation, third generation, fourth generation, and all of these are still on the market. So there's a heterogeneous class of products. The evidence we reviewed in the report is inadequate to infer that e-cigarettes in general increase smoking cessation. The evidence was suggestive but not sufficient to infer that the use of e-cigarettes that contain nicotine is associated with increased smoking cessation compared to the use of e-cigarettes that do not contain nicotine. And the evidence was suggestive but not sufficient to infer that more frequent use of e-cigarettes was associated with increased smoking cessation compared to less frequent e-cigarette use. I think Surgeon General Adams did an excellent job highlighting the many areas of opportunity for ongoing research. The e-cigarette conclusions in this report were similar to the conclusions from the 2018 National Academies of Sciences and Engineering and Medicine report. And the report acknowledges that these conclusions need to be considered as well in the broader context of youth use and e-cigarettes. So Chapter 7 broadens away from the individual interventions and focuses on the clinic, the health system as a whole, and population-level strategies. And we use the CDC's 3 buckets framework to guide this chapter. This is a framework that focuses on how interventions work together between healthcare and public health. So bucket 1 is focused on traditional clinical prevention. So these would be your one-on-one interventions that occur in a clinical setting. Bucket 2 broadens those into interventions that may have clinical roots but may move beyond the walls of the clinic. So, for example, tobacco quit lines would fit into this bucket, as well as some of the coverage of healthcare services. And then finally, bucket 3 focuses on population-level intervention. These are the big macro-level policies that can happen in a large community or large geographic area. So in terms of bucket 1, that classic clinical work, there is evidence, sufficient evidence to infer that developing and disseminating clinical practice guidelines can increase the delivery of clinical interventions for smoking cessation, and that strategies that link smoking cessation to quality measures, especially if they're quality measures that have payment attached, can also increase delivery of smoking cessation treatment. In terms of bucket 2, those innovative interventions that can extend beyond the clinic walls, tobacco quit lines represent a population-based approach to motivate quit attempts and increase smoking cessation. And in terms of payment structures, provision and promotion of barrier-free, evidence-based cessation insurance coverage can increase the availability and utilization of smoking cessation treatment. In terms of bucket 3, those big population-based strategies, a number of strategies were reviewed. In terms of sufficient evidence, the evidence was sufficient to infer that many of these policies, including increasing the price of cigarettes, implementing smoke-free policies, conducting mass media campaigns that include the quit line number as part of them, funding comprehensive tobacco control programs, and including large pictorial health warnings on tobacco-packed cigarette packages, that all of those can increase smoking cessation. The evidence was suggestive but not sufficient to determine that plain packaging alone increases smoking cessation and can decrease the availability that decreasing the availability of tobacco products and exposure to point of sale tobacco marketing and advertising can increase cessation. And then finally, that restricting the sale of certain types of tobacco products like flavors, menthol, et cetera, can increase cessation, particularly among certain populations. So Chapter 8, which is the last chapter in the report, focuses on the vision for the future. This is traditionally what the last chapter of Surgeon General's report focus on. It also provides some historical perspective in addition to looking ahead. So this figure, I think, is familiar to all of us. It shows the per capita annual cigarette consumption among adults as across major smoking, health, and policy events over more than a century now. So we can see that while there have been declines in adult smoking over a number of decades now, they have been in part due to policies and events that have decreased youth initiation. So we know that a continued focus on helping adults to quit remains critically important for further reducing the prevalence of cigarette smoking. And the 2014 50th anniversary Surgeon General's report reviewed a number of endgame strategies, and I'm sure they've been discussed at the conference this week. That report reviewed their relevance to the United States, and I think importantly for the context of this report, those strategies, while they aim to get us to the finish line, should not stand alone. Employment of any of those strategies, which you can read here, should be coupled with a focus on tobacco cessation and the delivery of the interventions and evidence-based approaches that have been detailed in this report. So key takeaways from this report as we wrap up this presentation, and I think Surgeon General Adams highlighted many of these, so I'll be brief. 34 million adults in the U.S. still smoke and are still at risk for all of the smoking-related morbidity and mortality. One of the most important actions they can take is to quit smoking, and this is true regardless of their age or how long they've been smoking. There are proven treatments and strategies to help people quit smoking. I think importantly, this report reviews some of the advances in those treatment areas since the 2008 clinical practice guidelines. And in addition, we need to ensure that people have access to these interventions, as well as we need to continue to explore novel strategies that can continue to help people quit. So I think to end the toll of this tobacco use epidemic, the evidence-based strategies in this report must be fully implemented, sustained with sufficient intensity and duration, And if this doesn't happen, we know that 500,000 Americans will continue to die each year from smoking-related diseases and exposure to secondhand smoke. Millions of Americans will continue to live with serious smoking-related diseases, and it will cost our society hundreds of billions of dollars. So smoking cessation is definitely an important part of this equation. I've shown here some of the resources that Surgeon General Adams mentioned as well that are available for all of you to get more information about the report. And I think I went fairly fast, so I think we do have some time for questions. I'm not sure how that will be moderated in the room, but thanks for your time and attention.
Thank you, and a big round of applause. So we can take questions. If anyone has questions on this session, you can come to the mic. Please.
Deborah Arnott from ASH. Just to say, brilliant to have this presentation and great to have the Surgeon General here, really impressive. I just wanted to pick up on e-cigarettes because the medicines regulator in the UK basically came to the conclusion that there is very good evidence for nicotine replacement therapy to be effective in helping smokers quit, and that on that basis, as long as e-cigarettes could be shown to deliver nicotine at least as effectively as NRT, that efficacy is proven. So what they are looking for in applications for a medicines license isn't proof of efficacy, but proof of delivery and safety and reliability, et cetera, et cetera. In that context, I'd just really like to ask for comments and also for why there isn't more research going on. I mean, you know, there was a slide about all sorts of other things which are suggestive of maybe being helpful, like vaccines, which are going to be really expensive and take a long time to deliver. If in the US they believe there isn't sufficient evidence, where is the research going on to prove whether or not e-cigarettes can be effective in quitting? Because actually that's a really important conclusion to reach, given that this is something which, if we can accept that there is sufficient evidence, can be delivered quite quickly and easily, unlike many of the other interventions that are being looked at.
Rachel, do you want to start?
Yeah, sure, absolutely. Thank you, Deborah, for your question. First, I want to say that I think one thing that's notable about this report is, and the conclusions that were made in the analysis of the literature by the experts that provided it and our team, is that, you know, it's really consistent with our National Academy of Science, Engineering, and Medicine review. So in that way, it didn't really change that much. I understand that, you know, the project study was out post that report and may be considered, of course, and was considered in the SGR. But I think looking at the totality of the evidence is important. It's that the totality of the evidence here and that was reviewed, which included studies in other countries, as you note, where the RCTs have been able to be conducted, which is not the case here in the United States, really still found that there wasn't sufficient evidence to infer substantial benefit, and that there's still inadequate evidence. I think that the issue is that there's still mixed findings, and that all the evidence has to be taken into account from all the types of study designs, including longitudinal, observational, population-based study designs. So we also acknowledge that there are different contexts across different countries in terms of the policy environment as well as the use patterns. In the United States, as you know, we have experienced a huge increase in youth use to what has been termed by the Surgeon General himself epidemic proportions. So I think we need more research still, and there's really, you know, a very important consideration to understand and balance the potential benefits to smokers with the potential risks that right now, at least in the US, are very real to youth using e-cigarettes and becoming addicted to nicotine. As you alluded to, there are policy issues in this country with investigators needing to obtain an IND to do trials where the endpoint is smoking cessation for trials for therapeutic intent with these products, and that is not able to occur at this time. But there is ongoing research funded in the United States regarding observing use patterns, including impacts on cessation, as well as switching studies. So there is evidence that will inform this, but we do acknowledge the point that you're bringing up.
Great.
Jillian, do you want to add any?
Nope, that was very thorough.
Okay, we have another question.
Thank you. Hi, it's Masuma from University of York. First of all, nice presentation. Lots of things we have learned. I just wondering, considering the wider determinants of health, that perspective. We know smoking is highly associated with social deprivation, like poverty, unemployment, this type of wider determinants. So in cessation, in any part of this Surgeon General's recommendation, was that point addressed? Or any future guidance, how the studies could address that? Thank you.
Yeah, thanks. This is Jillian. Thanks very much for that question, and I think that's an important point that there are a broader set of social determinants of health that may be impacted. As the Surgeon General noted, this report was 700 pages just reviewing things that were very tangential to cessation, and I think we, as a senior editorial team, felt like there were a lot of opportunities to make improvements in those areas. So some of the chapters touch on some of the determinants that you mentioned in a cursory way. For example, chapter 3, which focuses on the epidemiology, talks about some indicators that fit into sort of that social determinants of health category, but there's not a chapter devoted to it, and it was not a huge focus of this report, in large part because there's a lot of effort that we felt was needed really just on some of the practical variables. But I do think that that's important context, and appreciate you raising that question. Rachel, do you have anything to add?
No, thank you so much.
Seeing no more audience questions, I want to thank you both, Rachel and Jillian, for being present with us today and for your work on the report. This was a great session, and we'll move on to afternoon sessions. Thank you again.
Thanks, everybody.
Thank you.